welcome back to Anesthesia Coffee Break, and this is going to be our part 2 of neurophysiology. Welcome back, Arjit.
Hi, everyone. Ready to go for part 2.
Yeah, so we're talking about intracranial pressure. Tell me about ICP.
Yeah, ICP. So the intracranial pressure is defined as the force per unit or area within the actual cranial vault itself.
Right, so the force per unit area within the cranial vault. Great.
Depending on what reference you read, some state that it sort of sits around 5 to 15 millimeters of mercury, some say 8 to 12, 5 to 10, but these are all done in supine positions. So Lahira, what number do you sort of remember?
Yeah, I mean, that's probably the most relevant for us. So we're thinking about supine patients. I'm not too worried if they're standing or not. But when we think of raised intracranial pressure, often we look at a value of 20 if we don't have a specific ICP monitor in, like a Codman's or even EVD. So if we're not looking at the pressure, we'll just assume it's high. We'll assume it's 20. So anything less than that, we're looking at 10 as normal.
Cool. So the determinants that make up the intracranial pressure are brain parenchyma, blood volume, and CSF volume that's circulating around. So again, numbers sort of change depending on what reference you read. But in general, the brain matter contains about 80%, which is around 1.4 kilos to 1.5 kilos. Blood volume sits around 150 mil. So this can be about 10 to 15%, depending on what reference you read. And then you've got your CSF, which is about another 150 mil. So again, 10 to 5%, depending on what reference you read. So sometimes I've found when I'm doing a little bit of research from these things is that the numbers differ depending on what references. But Lahira, as you mentioned, I think examiners may have a bit of a range to play around with. Is that correct?
The examiners don't care, okay? So please, so pretty much from all your study, you'll have some confusion about wondering what is the precise answer. This is not the point of the exam. Just don't worry about the references. Pick a number. If it's a prescribed textbook, just pick that number. It's 1,500 grams. It's 150 mils. It's 150 mils of blood volume and CSF. Just don't worry. You'll be wasting time. And I've definitely had feedback when I was doing my exam from an examiner that said, stop saying that. Stop saying depending on the reference, because they know it. It's not getting you any marks. And this exam is an exam of getting through a lot of detail quickly. So it'll just be wasting time. Just pick a number. Don't worry about the ranges too much unless it's extremely relevant. And yeah, that's pretty much it. So what is the Monro-Kelly doctrine?
Yeah, so Monro-Kelly doctrine. So the cranium is a fixed vault, so it can't expand. So an increase in one of the brain matter, blood volume, or CSF volume must be compensated by a decrease in the volume of one or more of the remaining components to ensure a stable ICP.
Yeah, excellent. And what's interesting about that, practically speaking, is the brain, the brain itself comprises tissue as well as the interstitial stuff. So if you think about it, that could be tumors, but it could be, fluid inside the interstitium, and both can be treated in different ways. And we'll go through more of that in a second. What are some examples of pathologies in each of those components?
So in brain tissue, you've got tumors that we spoke about. But then you've got cerebral edema as well, secondary to you've got your trauma, infection, infarction, electrolyte disturbances, liver failure. A lot of those things can cause cerebral edema. Then you've got cerebral abscesses or contusions that can also cause that inflammatory response, which can then expand that brain parenchyma.
Fantastic. How about blood?
You've got your intracerebral, subarachnoid, subdural hematomas, and obviously your extradural hematomas as well. Dilation of the artery secondary to hypoxia, hypercarbia, which we'll talk about in a second, and all these things that can lead to an increased amount of blood flow within the actual blood arterial system. And then we talked about venous dilation from our previous episode. So secondary to venous obstruction, that could be us doing it through PEEP. It could be coughing, straining, heart failure. Positioning is really important as well. And other things are potentially neck ties that we actually have around our ETTs that could also cause venous dilation.
Yeah, so those will be preventing venous drainage from the neck veins. How about CSF? When does that increase?
So CSF, there's hydrocephalus, which can do it, meningeal diseases, and then you've got your choroid plexus tumors as well, which are relatively rare, but still something to know about.
Right. And so when I think about all of these practically, so that's exactly the way you should probably structure learning this for the primary exam in categories, knowing how things might change. And then, I mean, again, clinically, it's all about reduction of ICP. And, so you can think of reducing the brain tissue volume. So that's literally surgery or drainage of things. But the edema is where we can have effect, where we give hypertonic saline, three normal saline, or mannitol and steroids. This can all work. And finally, you can do a decompressive craniectomy to remove that, make the vault not a vault anymore, and that allows a decrease in pressure. And there's this DECRA trial that showed no benefit of it, and there's a whole kind of rabbit hole to go down with that, and the problems and the situation with that. Blood volume. So this is going to be evacuation of your hematomas, avoiding all your problems. So tackling normal oxygenation, normal CO2, or low normal CO2, normal glycemia, normothermia, as well as reducing the serum RO2 of the brain by pretty much giving a whole bunch of propofol or thiopentone to cause an isoelectric EEG. And we already mentioned the things that you can do for improving venous draining, putting the head up, loosening the ties, avoiding, well-paralyzed patient who's not straining, and avoiding PEEP or excess pressures in the lungs. And CSF volume, if you've got an EVD, an extraventricular drain, that way you can actually take some CSF out to help with the ICP. Now, this is a really good way of structuring categorically everything you need to do from an anesthetic point of view. But what I often will do, practically speaking, is think of physical things, physiological things, pharmacological things, and other more invasive things. So when I think of physical, that means what are the things like the ties around the neck? Should I loosen them? Should I put tape instead? Putting the head up, and turning off PEEP and making sure the patient isn't straining. So those are like the physical things. Physiological, just make sure all my numbers, my ABG is normal. So that's oxygenation, that's CO2, that's blood glucose, and then temperature. So those are my physiological variables that are very, that work very rapidly with blood volume. And then pharmacological. So that's what can I give this patient? Can I give them paralysis? Can I give them barbiturates? Can I give them more glucose if I need to? Steroids, whatever it is. That's the pharmacological stuff. And then other, meaning, do I need to drain some CSF? Do I need to talk to the surgeons about what's going on? And do they need to do a decompressive craniectomy or some other thing to release the pressure? So I find that is a far more clinically applicable way of doing things. But you might want to do either when you're in that. When you have a patient with high ICP. So we talked about this in the last episode. What is the standard number for cerebral blood flow?
So cerebral blood flow equals 50 mils for every 100 grams of tissue per minute, equating to about 750 mils per minute. And it's about 15% of cardiac output.
Great. So you'll be learning that for a whole bunch of organs, the brain, the heart, the kidneys. How about oxygen consumption in the brain, or CMRO2? What's that number?
This number here is 3.5 mils for every 100 grams of brain tissue per minute, or 50 mils in total per minute, or 20% of your complete O2 consumption.
Yeah, fantastic. So that's 60% of the activity-based and 40% for basal activity. So the maximum, when you cause an isoelectric EEG with large doses of propofol or thiopentone, pretty much you're getting rid of that 60% of activity, but the basal activity, just for homeostasis, just for regulation of your brain tissue, is still occurring. But you can get rid of 60% of activity, and maybe it's going to provide some level of protection for the brain. The other thing to do is absolutely learn the 3.5 mils of oxygen per 100 gram per minute, or the 50 mils, or 20% of O2 consumption. Learn it in parallel with all the other organs, just so you have something to compare each of these things with. And it does get confusing, like looking at blood supply and looking at oxygen consumption. You've just got to have a system for learning it. I found comparing them between organs the easiest way for me to remember them, rather than learning organ specific in isolation. So tell us about, I think, this cerebral blood flow globally is probably the most important number to learn, and the CMRO2. There's a whole bunch of other numbers I think are less relevant. How about, let's talk about cerebral blood flow and the equations that are relevant, and then the factors as well. Let's start with the equation.
We've talked a lot about cerebral blood flow. So cerebral blood flow, CBF, often it's abbreviated to, is MAP, so mean arterial pressure, minus your intracranial pressure. Or if your CVP is higher, then you minus your CVP from your MAP instead. But most of the time, it's going to be your intracranial pressure. So MAP minus intracranial pressure divided by cerebral vascular resistance or cerebral resistance, which again and again, our favorite formula for your Hagen-Pascal equation will keep coming back. And again, one of your biggest parameters that impact this is the radius of your cerebral vessels, which is just what we talked about.
Right. So we're looking at 8 times the length of the vessel times viscosity over pi r4. And just like you mentioned, saying how important radius is, it's got an exponential increase in your resistance. So overall, it's your cerebral perfusion pressure over your cerebral resistance or cerebrovascular resistance, which is your 8L times viscosity over pi r4. So what are the factors then that affect cerebral blood flow?
So there's factors that I break them down into 4 different categories. So there's chemical / metabolic, which includes your PaCO2. Then you've got your PaO2. Then you've got your vasoactive drugs, and then you've got your cerebral metabolic rate within these parameters. Then you've got myogenic control, which is the pressure order regulation. Then you've got rheologic, which talks about your blood viscosity. And then you've got your local neurogenic response, which are like your sympathetic and parasympathetic pathways.
Right. So again, when I think about this, categorizing it as chemical, myogenic, rheologic, and neurogenic, and then going into detail is really useful. So if you get asked a question about this, you can say there's these 4 factors: chemical, myogenic, rheologic, neurogenic, and then go into whatever you want. Sometimes the examiners will direct you down the chemical path because they might just want to talk about CO2 or oxygen. So these are probably the most important things, especially because we can manipulate them. Tell us about the PaCO2 and its effect on cerebral blood flow.
Okay. So PaCO2, with each millimeter, so each 1 millimeter of mercury of increase in your CO2, you can have an increase of 2 to 4% or 1 to 2 mils per 100 grams per minute of cerebral blood flow between a range of about 20 to 80 millimeters of mercury of your cerebral blood flow. As with most things, the CO2 in the brain, the change is mediated by the pH. So it's the H plus ion rather than the CO2 directly affecting that. The important thing here is that hypotension can decrease this ability, and this response to CO2 is rapid, but only lasts about 8 hours or so. So after that time, your brain matter can actually regulate your pH of your cerebral spinal fluid, and then this PaCO2 response is actually abolished.
Okay, and you can see that there will be a sinusoidal type curve for this. So yeah, really important that we keep CO2 in the low normal range. So most people would, first of all, practically speaking, you have your end-tidal CO2, which is not your PaCO2, but it'll have some level of correlation. You take an ABG, so you know your PaCO2 and your end-tidal CO2 and roughly what the gap is. And then you target hopefully a PaCO2 around 30, because you just want it to be at the lower end of normal. There wasn't really any value shown in decreasing below 30 over long periods of time. But potentially, if there's a sudden increase in ICP, you might want to hyperventilate the patient, remove CO2 so that your end-tidal CO2 decreases acutely at least to 20, 25, just while the surgeons need some space if the brain is really swelling and the ICP is increasing. How about oxygenation and its relationship with cerebral blood flow?
Yeah. Just before we go into oxygenation, I think, as you said, Lahira, really important that a lot of these graphs that are there are examinable. So make sure that you have a look at all these different graphs of these different variables that we're talking about, and have a sort of way for you to work out how we're going to draw this graph in a pressure environment. There's one really good one that combines O2, CO2, and cerebral metabolic rate, as well as your pressure autoregulation, which can be found around. And I think that's probably one that you should remember. But going on to oxygen, your cerebral blood flow increases when it hits about 50 millimeters of mercury. And again, different references say 60. Hypoxia is 60. So I like to think of it as under 60. And Stan Tay, the guru of this as well, is also said he goes by 60. So if he says it, it's my Bible as well. So under 60 tends to you start to compensate. Your cerebral blood flow increases when it's hypoxemia.
Beautiful. And absolutely remember the difference between hypoxia and hypoxemia. Hypoxemia refers to oxygen in the blood. Hypoxia as a tissue level. And just a bit of a recap. So you can have hypoxemic hypoxia, and that's due to low oxygen tension in the blood or low PaO2, but you can have stagnant hypoxia, cytotoxic hypoxia, and anemic hypoxia. So just being really specific about that. I know it gets used interchangeably all the time, but if we're talking about primary exam stuff, it will be very confusing if we mix the two terms. Good. So how about cerebral metabolic rate?
Yeah. So there's a linear relationship between cerebral metabolic rate and cerebral blood flow. So important in temperature physiology, right? So a change of every degree of Celsius that you can cool this patient is a decrease of about 7% of your cerebral metabolic rate. So you can make quite a big difference by cooling, which is why often cooling strategies are one of those things that we use for when we're neuroprotecting a patient.
Something like it's far more done in ICU. You know, when I'm in theatre, I'm not really going to maintain this by any means, but this is very relevant for primary exam.
Yeah.
How about this is far more important for us: pressure autoregulation and cerebral blood flow. Tell us about that.
Yeah, so pressure autoregulation is done through the Bayliss effect. So the cerebral blood flow is kept at a constant map range, which is really important because if you think about it, if you're coughing or if you're doing any sort of straining for a brief period of time, then your map's going to go up and your cerebral blood flow is going to go up temporarily, but we're not all going to go up in our pressure, right? So usually the map range is about 50 to 150 millimeters of mercury in a normal person, and that's where you can compensate and you can keep your cerebral blood flow at a constant level. Under that amount, you've got a steep decrease, and over 150, you've got a steep increase.
Yeah, great. And you'll see different numbers based on if they're talking about MAP or perfusion pressure. So you can imagine if it was cerebral perfusion pressure, it would be, MAP take away your ICP. So your numbers might change. So just be cautious of what the x-axis is. Just choose one and go with that. But it will change if you got pathology. So you know what's really interesting about this? So imagine you've got this graph. So please just Google pressure autoregulation of cerebral blood flow. You've got this graph which has a plateau between about between 50 and 150. And the interesting thing about that is in a healthy brain, so this is non-anesthetized, non-traumatic, for the cerebral blood flow to stay the same as your pressure is increasing, your your arteries actually constrict, which means that your ICP actually decreases. So from the range of 50 to 150, as you increase your MAP, your ICP decreases, which is interesting, right? Because it would seem as if cerebral blood flow is staying the same, or your MAP is increasing, it might be counterintuitive that your ICP actually decreases, but that's what happens because your blood vessels are constricting. So that's a bit of a trick with this whole situation. But this is probably less relevant for us because we're dealing with anesthetized brains. and traumatized brain. So as soon as you get that, you lose a lot of, you lose some level of this autoregulation, and you've just got to choose a value that seems like it will be a good balance of perfusion, but also not causing an increase in ICP. So that's where it gets really tricky. And, if you've got devices in to measure what the ICP is, it really helps you to, get the right map pressure for ICP and try to maintain, that really good balance.
Lyra, can I just ask quickly, there's a lot of the times, sorry, this is off the cuff, but a lot of the times we talk about volatile anesthetics and this mechanism of autoregulation, not necessarily pressure, but what kind of things should candidates / people, trainees know about with volatiles and the cerebral blood flow?
Yeah, it's off the cuff. So when I was learning volatile anesthesia, it was from, especially as it relates to intracranial pressure and CMR2 and cerebral blood flow. Probably the most important thing is that different volatiles will have different effects, and it also has different effects based on the MAC. So if it's less than 1 MAC, it might actually be totally fine, but greater than 1 MAC, you may lose a lot of autoregulation. I can't remember the detail of that, but if you look at, say, a book like Peckhill and Williams, Pharmacology and Anesthesia Intensive Care, that I think that had a really good summary of the effects of volatiles at different levels, which means that for most situations, running a sevoflurane anesthetic for your neuroanesthesia is totally fine, as long as you're not, cranking up that sevo dose to be 1.5 MAC, it'll probably be okay. But generally speaking, what we do with tight brains is we use propofol Tiva, and usually running remifentanil as well to keep it really stable. And that, both those, so propofol Tiva will have the effect of preserving some level of autoregulation and minimizing the ICP increases, and then running remifentanil will have the effect of, you're essentially paralyzing the patient as well with that. So there's less need for constant infusion of muscle relaxants, but it also will keep, any kind of pain spikes really under bay as well. So yeah, there's many ways of doing this, but that's probably just one thing a lot of anesthetists would run their neuro cases with.
Yeah, and that's what I've seen as well with the remifentanils, and the wake up is a little bit more controlled. You don't get as much sort of coughing and those spikes in intracranial pressure, as you said. Yeah,
and I mean, got to be honest, the neuro anesthesia isn't very painful for the patient. Often it really is the skin layers, the bone and the dura, which is perhaps, nociception. The brain itself doesn't. So it's very easy to anesthetize that with scalp blocks, as well as, just a little bit of remio-opioid. But you really want these patients to wake up smooth, like you said, not coughing, and you want to have a rapid assessment of neurofunction. And so remifentanil, shutting that off and having them with minimal opioid is the best way the surgeons can assess their brain function in response.
Perfect.
That's good. So we went through quite a few things there. So we talked about ICP, the definitions, the contents and the amounts, the Monroe-Kelly doctrine and its definition, talking about brain tissue, blood, and CSF and the components in pathology states, and what we can do as anesthetists to treat that rapidly. We talked a bit about CMR2, the determinants of cerebral blood flow, and the graphs of CO2, oxygen, as well as the pressure autoregulation graph as well. So lots of good graphs that you need to learn, lots of interesting principles, and again, very practical, and when we're providing anesthesia.
Yeah, exactly. I think for me, as a very junior, these graphs are actually a lot easier to learn than like respiratory ones. So I'm sure everyone will be fine learning these graphs.
Yeah, there's just 3 really. So you're welcome. Yeah. Thanks very much for watching and listening, everyone. So that was ICP. Please share with anyone who might be interested. Thanks again, Archie, for coming along. It's really great fun to be recording this stuff, and I get to relearn a lot of this thing, and you'll be sitting your primary exam hopefully soon.
Yeah, I hope so sometime. Thanks, everyone. All the best.
See you. Bye.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.